everyone, welcome to This Week in Recovery. My name is Lindsay Cochran. I'm part of the Lackawanna Recovery Coalition, and I also work at a local treatment facility as a family counselor. Today with us, we have Dr. Karen Arscott. Hi, Karen, how are you?
Hi, great. How are you?
Well, thank you. So before we get started, would you mind just telling our viewers a little bit about yourself?
Sure. So I'm from this area originally, and been a doc a long time. I graduated from med school back in the 80s. I've done so many things. I've had general practice. I'm boarded in neuromuscular medicine. I was a hospitalist for a period of time in Philadelphia. Then most recently, I was teaching at the medical school in Scranton for the last 8-9 years. I'm an associate professor of medicine. During that time, though, I met someone who was working in a medical assisted treatment clinic, and I expressed that, it was something that I found interesting. And so I went and did the waiver course and started working at that clinic part-time while I was still at the medical school, and found that I loved it. I love taking care of patients with any type of substance use disorder. What I found in these people were patients who really just wanted somebody to care about them. And so as a physician, that's like great, So, but I found that I didn't know enough. So I'm now a fellow in addiction medicine, a fellowship program, so that for 1 year to really be in depth in substance use disorder and learn as much as I can before going back out to start treating patients in that world. So that's kind of where I come from. It's really a specialty that is really very important, I think, is in this time. And I think it's important for those who go into it to understand the substance use disorder is a disease. And so that's the way I look at it. And that's what it is.
Yeah, absolutely. I would agree. Thank you. And speaking on, medication assisted treatment, can you tell us a little bit more about what that actually entails?
So sure. I think we have to go back to the substance use disorder as a disease idea. First of all, our bodies are amazing, and we have these neurochemicals in our brains and throughout our bodies that, communicate with each other, and they tell our bodies what to do, how to feel pain or not pain, how to feel joy, how to be happy, how to be sad. So we have these neurochemicals that are constantly like working in our brain. When we take different substances or even exercise, we change those neurosubstances. We can have them emit larger amounts of them to give us, that runner's joy if you're into running or exercising. We can, there's different ones if we don't get enough sleep, where we can start feeling depressed because the neurochemicals change. So there's so many different ways that our neurochemicals can be impacted by different things we do. And one of the other things that can impact them, though, is taking something in that causes a change in those neurochemicals, whether it be increasing them or decreasing them. And so medical assisted treatment works on the neurochemicals. That's really where it's based. So if we start taking substances that change those neurochemicals, and then we try to stop abruptly, we have withdrawal. If we have taken them enough that we build not just a tolerance, but a dependence on those chemicals to keep our neurochemicals normalized. And when that happens and we stop those and we develop, withdrawal to that agent, that can be anything from an unbelievably uncomfortable situation to death, to seizures and death. So medical assisted treatment really is where we control, the neurochemicals as best as we can. I always like to tell patients what we know about neurochemicals now is much better than we did 10 years, 15 years, 20 years ago, but it's nowhere near what we're going to have 20 years from now. I think, this is a developing field. So medical assisted treatment really is where we control at least somewhat the neurochemicals that maybe have been changed by substances and such that we take.
Do you foresee that's why that's often recommended over someone just quitting cold turkey?
So, this is a tough question because there are people who quit cold turkey. There are, especially now, that's only certain substances. Because certain substances like benzodiazepines, so Xanax and Valium and different things like that, or even alcohol, if you develop a dependence on it and you quit cold turkey, could result in seizures and death. So we never recommend that. Those chemicals are very dangerous. And so the resultant withdrawal could be very serious. Things like opioids, opiates, if you have withdrawal to that, it's like the flu on steroids. It's like 10 times worse than the flu. It's a very, very hard withdrawal. However, people don't die from opioid withdrawal. So some people do quit cold turkey, and it's it's far from pleasant, but it's doable. The problem, though, is that your neurochemicals are still unbalanced. So the possibility of relapse is great. Relapse is part of the disease of addiction, and so we know that. And for alcohol, your neurochemicals will not return to a normal state for up to 12 months after your last drink. For things like opiates, amphetamines, benzodiazepines, it's anywhere from 18 to 24 months of abstinence before your neurochemicals normalize. So knowing that anywhere during that time period, the possibility of relapse is huge. And so, that's what we're trying to avoid is that relapse. So who is this for? Really, it's medical assisted treatment is for really anybody who wants to get their life together, and have control. I think it gives us more control over the recovery than cold turkey, where you're really you're out there just kind of doing the best you can. Do people do it? Absolutely. Everybody, whether you're quitting cold turkey or whether you're in a medical assisted treatment program, should be getting counseling. That is so vital that you have counseling and therapy services throughout that whole time. And again, as long as your neurochemicals are out of balance.
And I think just to tie on that, just knowing how you had mentioned the time frame after eliminating the use of the substance, whether it's alcohol or whatever the case is, or an opiate, there's still all of these underlying layers that still need to be addressed and treated in order to reduce that risk of relapse.
Right.
Now, I know when it comes to medication-assisted treatment, oftentimes people say, well, it should be worst case scenario, like a last case resort, that at this point, if you've tried X, Y, and Z and had no success, then you should turn to medication-assisted treatment. Do you find that that's the case, or would you recommend that process start earlier?
So I'm going to say that that's the way most people do it, because most people, they don't want to do this. They don't want to do the medical assisted treatment. Most people have tried to quit on their own. Most people have tried cold turkey. I can't think of any patient who came to me and said, no, I haven't even tried to quit. I just want to do this, they have tried and they have failed and they have relapsed. And every time they relapse, the risk of death is greater, because we know overdoses happen. So, as far as that goes, I think that it's for people who really want to get control of their substance use disorder. I really do believe that medical assisted treatment is a way, because we put people in touch with, the counselors, the therapists that are so vital. And then we also help control those neurochemicals. Again, I get, people can try. Most people have tried to quit on their own before seeking therapy.
Right. Now, how long would you recommend medication-assisted treatment? And I know, that answer probably varies, but is it something that's a lifelong commitment, or is there essentially a recommended time frame?
So there's nothing recommended. I'm going to tell my experience so far has been, though, I have people who have come to me who started maybe, believe it or not, using heroin at the age of 11 or 12, an uncle or somebody gave it to them, a boyfriend or a girlfriend or whatever. At a very young age. We know that the human brain does not fully develop until about 25, 26 years old. So you're now using a chemical that's altering your own developing brain's neurochemicals for more than half your life before that brain develops fully. So how long is somebody like that going to require medical assisted treatment? I don't know. Could they need it for the rest of their lives at a low dose? Perhaps. Oftentimes we can get people who maybe have been on heroin or something, or fentanyl for long periods of time, and we can get them down to a very small dose of buprenorphine, but we can't get them off of it. I don't know. Maybe they, but so the question then is, what's our goal? If our goal is to help people become productive members of society, parents, children, have a job, be able to actually be part of our society, our community and such, what if they have to take a little buprenorphine every day to do that? I don't see a problem with that. Now, let's take it the other way. There might be somebody who, they're in their 30s, they've never had, a substance use disorder, had some kind of surgery. They are prescribed, Vicodin or Percocet or whatever post-op. Somehow they slip through the cracks and they keep getting it for a couple months. And now that suddenly they find that they have a dependence on it and they want to get off of it. And they find that they can't stop it lately. Without losing their job, because again, withdrawal makes it hard to work. when you're going through withdrawal, that's you're sick, and you don't want to. There's a stigma in our society, so they can't go and tell their boss, "Listen, I got to come off this, so I'm going to go through withdrawal for the next week, so I won't be into work." So people can't do that. So we can, those people are the ones that I think potentially could take medical assisted treatment for a period of time and wean off and maybe be able to come off. Remembering though that those neurochemicals in your brain are unbalanced for a long period of time. And so, to say, well, I'm just going to take it for 3 months or something like that, I don't think is realistic. I think that most people are going to need it for a period of time to try to, again, I look at it as a way to control the use of a substance. And then you can slowly wean that substance down. And I think that's our goal.
Yeah, and I think, that in combination with the treatment team, which is targeting some of the other areas that we had discussed earlier, again, the ultimate goal is to become a productive member of society. So if I'm able to do that, gain employment, maintain relationships, have a positive support network, and maintain my recovery, rather than place a time frame and say, well, here's the end date. Don't focus on that, just focus on what's happening and what I'm gaining in the process.
Right. Absolutely. Well said. Yes.
Absolutely. And now I know, because you had mentioned stigma and what comes with medication assisted treatment, there's often stigma associated there with, for example, you're replacing one addiction for another, you're using this as a crutch. How do you address some of those myths?
So first of all, we're not replacing one addiction for another, because addiction by definition is where you have negative consequences but continue doing it anyway. Mm-hmm. So when we're prescribing buprenorphine, they're not going out and stealing. They're not buying drugs on the street. They're not selling drugs to try to keep their condition under control. We're writing a prescription. We're controlling it. So it's not an addiction. It's a treatment. So that's the one thing. And so when people say you're trading one addiction for another, it's not true. Because a true addiction means that you have negative consequences, but you continue doing it anyway. Mm-hmm. As far as a crutch, that we could say the same thing about many other diseases. Diabetes. So diabetes, is insulin a crutch? I don't think so. Are some of for type 2 diabetes, metformin, different medications that we give, are they crutches? No, they're not. They're treatments. And the same with, so we could talk about hypertension, is treating hypertension, because people should be eating healthy and getting exercise and doing all these things, and then they won't need their antihypertensive meds. So we're just giving them a crutch by treating it, right? No. So it's the same kind of a thing. If we think, first of all, we have to realize that this is truly a disease. It's not, these people, who would choose to live this way, like with an addiction? Nobody would choose this. And once they have a substance use disorder, choices out the door, it is now a true disease. And we have to treat them as though they have a disease, which they do. And so doing medical assisted treatment, again, we have to keep our goals in mind. And if our goal is to help this person become a productive member of society, then don't we want to do everything we can to help them achieve that goal? And so it's, it's just like, again, any other disease. It's not a crutch. It really is a treatment modality. And it has to be fine-tuned to that individual. It's not a one size fits all. It's really fine-tuned to each individual.
And I think too, looking at, like you said, it's individualized, right? So looking at, it's more so an aid and another tool in somebody's toolbox on the road to recovery, just like positive support network, having a positive, healthy environment that's conducive to where I'm headed in my recovery to reside in.
Yeah.
And to have just an extra tool in there to help, like you said, with the control, because if I could target that area, then my focus can go and focus on the relationships in my life and making sure that my self-care is a priority and that I am maintaining my recovery in other ways without becoming so overwhelmed with that aspect that, some of those other areas suffer. So again, the combination of a whole treatment team and looking at the benefits and the harm reduction and just being able to not just gain that sobriety, but to maintain the recovery.
Yes. So well said. It's so important. You know, this disease is a terrible disease. It truly is, and it warrants us giving it full on work. It takes a team to take care of these people, these patients, and they deserve it. And I just want to say one other thing in case there's people watching who are, you know, as a healthcare provider, I know that there are healthcare providers out there who are not nice to people with substance use disorder. And I think that's a shame. And so as a result, I've heard healthcare providers say, well, I don't trust them. But I'm going to say that I think, first of all, I think they have every right to not trust us because we haven't been kind in many respects. And so we have to develop that rapport with a patient. We have to show them that we care about them, and we have to earn their trust. I mean, well, we could go on about how the medical community has helped create this problem with opiates in particular. I've been a doc long enough that I've seen it. I've seen it develop. I've seen what's happened. I know how it happened. And so I think that we have to work together for these people and take care of them. And like you said, work as a team and work together to help them achieve recovery.
Yeah, and to break that stigma, like you had mentioned earlier, if I don't feel comfortable with even the issue that's at hand, if I don't feel comfortable enough to confide in somebody else, to even ask for help,
Right.
well, there's a barrier there. And that barrier is going to ultimately impact me in a negative way and continue, to contribute to the substance use disorder. So if that rapport can be built and that trust can be gained, well, now I'm able to look at what other options are out there and become more comfortable with the acceptance piece and start to look at what resources are available to me.
Yes, excellent, excellent. I agree completely. Very good. Yeah.
Yeah. And I think just to tag on, for the viewers watching, that there are resources out there. I mean, one in our area, but every area as well. And looking at different options for medication assisted treatment and knowing that it's not just like you had said, one shoe fits all, there's different routes you can take, and knowing that there are options to look at if one doesn't work or if I haven't tried this, what other options do I have to look into?
And you have to find a provider that you feel comfortable talking to and being honest with. If you relapse, be honest.
Mhm.
We're going to find out, but we need to know what's going on. If you use something else, you have to be honest. Many places now have the harm reduction, so where we don't just dismiss people. We really try to work with people because we understand that relapse is part of the disease. And so, find a healthcare provider and a healthcare team that works with you, and be honest with them.
Yeah, and tying it back to that it is a process, no one is perfect, us included, and being able to know that, okay, if I have a setback, is this a failed attempt? No, it's not. You could get right back up and look at, okay, well, what changes might I need to make moving forward? And knowing that I can reroute and still get to the same destination and have the same goal, maybe just make some changes along the way.
Right. Whenever one of my patients has a relapse or something like that, the first thing I ask them is, what happened? what was going through your head, because the relapse happened, you know, a couple days, it started way before. What
Right.
happened? So that should you ever be faced with that situation again, the outcome will be different. You know,
Mhm.
you'll be able to say, you know, no, or call somebody, get some help or whatever, but you need to reflect on what happened and why. So medical assisted treatment really, in my opinion, is a way of controlling um, the imbalance of neurochemicals. Let's try to take some control over it, and let's try to normalize them, you know, like in a way that makes people comfortable and productive members of society. That's the goal. That's the end goal
Right.
in recovery.
You know, on that note, Dr. Arscott, I just want to thank you for your time today and providing us and the viewers with all of this information and being able to allow people to know what options are available for medication assisted treatment.
Thank you. It was wonderful talking to you today, Lindsay.
Thank you. Enjoy the rest of your day.
You too. Bye.